Hi, my name is Michael. The idea of this next video is going to be focusing on rotator cuff tears of the shoulder, the common presentation that you'll find, as well as a few hands-on assessment techniques to see if manual therapy or physiotherapy is going to be helping those symptoms. Also, I'll show you a couple of exercises that will help improve the patient's strength, as well as get them able to move and function in their normal daily life. As we said, we're going to be looking at the rotator cuff. So the first thing that you'll get with the patient is going to be doing some active range of motion. So Nick is a 60-year-old checkout lady, doing a lot of repetitive external rotation of the arm, started finding a little bit of a niggle in her shoulder, and then it's just progressively gotten worse over time. She's come to see you in the clinic, gone for an ultrasound and found a degenerative rotator cuff tear. So what we'll do first, we'll get the patient in the clinic, we'll have a look at just the shoulder range of movement. So what we'll do first is thumbs forward, lifting the arms up as high as they can. Normally you'll see one arm struggling a little bit more, bit of pain on the face and doesn't want to go too far up. Then you get the patient to come back down. You will then get them pointing the palms forward, coming up and out to the side. Same kind of thing, not wanting to get up around that 90 degrees. Coming back down. We'll then look at external rotation, so elbows by their side, arms in a 90-degree bend, and just keeping the elbows tucked in, slowly coming out. Same kind of thing. Range won't want to go, pain will hit straight in the shoulder. Okay? The other one that they'll find is the most problem is hand behind their back. So with ladies struggling to get up, put their bra on. So what you'll do is one hand at a time, trying to get them to lift up as high as they can, doing the same with the other side, and you'll find that they'll probably get about towards the belt line and then not want to go any further. Okay? So once you've done those few quick tests, we'll know where the restrictions are. We now go on to our special tests, trying to isolate what is the problem. So with a lot of rotator cuff tears, you'll get some impingement, so the subacromial space will get trapped. The rotator cuff tendon as it comes through and the nerve that comes through get trapped as well. So what we'll start with first is the Hawkins-Kennedy, so looking for impingement signs. So we'll get the patient to come up into 90 degrees forward flexion, 90 degrees external rotation, getting the patient to relax their arm on your arm, depressing the shoulder down. You tend to get grimace on the face quite quickly with that. The main movement is you want to bring the arm in as you're holding down. As soon as they get pain, take them out and put the arm back down. You'll check both sides just to compare normal and abnormal. The next test will be what's called an empty can. You get the patient to bring their hands up out in front, turn their thumbs to face the floor. If it's an acute tear, they'll tend to find a lot of pain with that straight away. If they don't, apply a little bit of pressure, get them to resist, and you'll find that they'll get a lot decrease in strength and their arm will just want to give way. Okay? External rotation, same kind of thing. With rotator cuff tears, the main rotator cuff that gets torn is the supraspinatus, the main function of it being external rotation. So what we want to try is a bit of resisted, get the muscle activating. So same thing in that position, putting your hands on either side and just getting them to push against your hand. You'll find a lot of weakness and not as much strength and pain. Last, internal rotation. We'll get the patient to put the hand just on their bottom, not as high up as they can, and trying to lift their hand away from the bottom in that position. So lifting the arm back as well. They'll find a lot of pain with that and they won't want to be doing that. If you put your hand over the top, you can do a resisted movement as well, which will also be causing pain. So once you've done the special tests, you've isolated that it is a problem with the rotator cuff. What we want to do now is go into a little bit of treatment. So the first position we'll get Nick in to do a bit of assessment of the joints would be in lying on his stomach. You'd want the patient to be all the way off to the edge of the bed, shoulder hanging off the edge and hanging down. With the assessment, we're going to be looking at the AC joint, so the acromioclavicular. So what we want to do is, while we're at the back there, we want to find the spine of the scapula and collarbone, moving all the way across till we get to the acromion at the very end and everything joins, and then just applying a PA glide to the back. You want to be applying about 50% pressure just to see if there's going to be sore. You want to start shifting position as well, so coming a little bit back up. A lot of the time you'll get a lot of pain with this with patients, even just on light pressure, if they have an acute tear. or degenerative tear. The idea is we're introducing some movement to that joint, freeing up that subacromial space. After doing that for about 30 seconds to a minute, what will happen is you'll get the patient back up, reassess your forward flexion, and you'll find that the range will improve quite well. If that does, then manual therapy on that joint is going to be quite beneficial. As we come down, the rotator cuff is still inflamed, obviously with the tear. It's just freeing up the space, so that will take some time to calm down. That's where your anti-inflammatories and your medications are going to be helping out with that during the treatment.